Pleasure to introduce today's speaker, Dr. Teodor Grantcharov. Dr. Grantcharov is a professor of surgery and associate chief quality officer for innovation and safety here at Stanford. His expertise and accolades are really far too many for me to do justice to and still have time for him to present all of his work. So I apologize in advance for my introduction. But prior to coming to Stanford, Dr. Grantcharov worked extensively internationally. He completed medical and surgical training in Denmark. He was professor of surgery at the University of Toronto and received the Queen Elizabeth II Diamond Jubilee Medal for his contributions to clinical research and patient safety in Canada. He's also received honorary fellowships at Imperial College, London, and with surgical societies in Bulgaria, Denmark, and Brazil, to name but a few of his international awards and achievements. He's the founder of the International Center for Surgical Safety, which is a multidisciplinary group of visionary scientists with expertise in design, human factors, healthcare research, and computer and data science. He is really the expert on operating room safety, and so I'm very excited that he's here today to talk about his surgical black box concept. And so as usual, if you have any questions during the lecture, you can go ahead and put them in the chat. If there's any points of clarification, I'll go ahead and interrupt Dr. Grantcharov to get those clarified. Otherwise, we'll hold them at the end for a discussion at the end. And as usual, we'll try to end about 10 minutes before the hour. We'll have about 35 minutes of lecture and then time for questions. And with that, I will hand it over to you, Dr. Grantcharov.
Thank you so much, Laura, and thanks to Lisa Freeman for inviting me to share some of my work here today. As Laura mentioned, I started and throughout my career, I've been practicing medicine and surgery in many different healthcare environments throughout Europe, US, and Canada. And I've learned something each of these places. I've also seen a lot of amazing things and not so great things each of these places. So the main conclusion is the perfect place doesn't exist. But there is something that we can learn from these experiences and continuously work to make our ORs, our clinical environments here as safe as they can be. So to start with the disclosure, as a process in Toronto, as a process, as one of the steps in the knowledge translation of some of our work, we created a academic startup, Surgical Safety, and I'm the founder of that. So I'll start with this quote that I really like from that book, Atomic Habits, and it always reminds me that quote. I always remember that quote when I hear the ambitious goals that our organizations share in the beginning of every year or every fiscal year. We want to reduce never events. We want to reduce surgical or hospital-acquired infections. We want to reduce the number of anastomotic leaks and so on, which make a lot of sense in the boardroom, but not necessarily make a lot of sense at the front lines because identifying goals and trying to change outcomes is an exciting opportunity. But at the same time, if we fail to study our process and identify what can each of us in our daily work do in order to change the process or to continuously build that process or system, we will inevitably fail to achieve these goals, and every year the outcomes measures will be a lottery. So I think one of the most exciting things, or one of the things that excite me when I moved to Stanford, is try to understand the outcomes and the process measures that lead to these outcomes, and then work on a few specific opportunities to improve process and see how that translates into change of our outcomes. I think some of the early days when I started this work more than 20 years ago, some of the early thoughts on safety were that if we keep recruiting the best and the brightest and keep investing in high quality training and build high performance simulation centers and keep developing standard operating procedures, evidence-based standard operating procedures, and follow these procedures and use the latest, most modern equipment, we will achieve safety. We quickly realized that these thoughts were fairly naive. There's still a lot in our daily work that's unpredictable. We will continue to see. We see and will continue to see a lot of uncertainty. I think the only way we can make the transition then that other high-risk, high-performance industries like aviation, nuclear, aerospace, oil industries have done to transition from safe to ultra-safe, from reactive to proactive. We need to have a better understanding of risk, and we have to continuously capture higher quality data than we do today in healthcare, and particularly in surgery. And the reality is that in 2023, the surgical operating theater still remains one of the most secretive environments in modern society, and probably one of the least understood environments in healthcare. I think there is a lot of effort still required to make a change here. And I think one of the the interesting phenomena that is universal and well studied in human factors literature is the phenomena of work as done versus work as imagined is alive and well. And we still, our perception is of the environment is can be fairly different than reality. So this is some of the work that we did in Toronto a few years ago, looking at, we surveyed every single team member in the operating room, and we asked them at the end of the procedure, what do you think, how do you think this procedure went? Was there something else of the norm? Was there an adverse event? Or was it perfect? And in 75% of the cases where there was a high severity adverse event, the team's consensus was that this procedure was perfect. When we talk about one of the fundamental quality improvement interventions in surgery, which is the morbidity and mortality meeting, we usually takes place a week or 2 weeks after the surgical procedure. We can imagine that the value of that meeting will be quite limited, because if we can't remember what happened at the end of the procedure, most likely we will remember even less a week or 2 weeks later. And this is what this study demonstrated. We spent some time in and tried to learn from other high performance industries. Professional sports is one of those. We all know what video analysis and data analysis that did in professional sports. We can't imagine a professional athlete or professional team, or even a college and high school team these days without video analysis and without some form for data science implemented in the improvement process. And yet we don't do that in our surgical practice. We still don't do that in surgery. And we often ask ourselves the question, why is that the case? And there are a bunch of cultural issues here that probably are the most difficult to address. As I said before, the surgical operating room has become one of the most secretive place in modern society. What happens there stays there. The moment we exit the operating room, we either forget or deny or ignore. And when we enter it again, there is a pretty high probability that the adverse events or things that we want to avoid will continue to happen. The other thing is our perception of the reality, and this is how a typical surgeon thinks about the day in the operating room. I can clearly remember my first surgical procedure early in my career in Copenhagen, where I felt that nobody could do this procedure better than me anywhere in the world. Until the day I saw the video, and it was a VHS tape at that point. And it was quite embarrassing. I go through this now when I try to improve my golf game or tennis game, and somebody takes a video clip. It's certainly not as good as I thought it went. And this is a reality. This is our perception of reality is very different than the reality, and this is a quite widespread phenomena especially in surgery. The last thing is I still use this picture of the hospital where I practiced before I moved here to Stanford, St. Michael's in downtown Toronto. We had a state-of-the-art simulation center. I had 35 graduate students, research team. And one day I asked myself the question, okay, after we published our 200 or 300 manuscript, I asked myself the question, how many of these manuscripts actually made it to the real world, to the patient care, to the OR, to the patient bed? And then I was walking and saw this bridge here, this symbolic bridge, which connects the hospital environment with our research institute. And it was shocking to look back and see that how few of the massive amount of evidence that we have generated and the massive amount of the evidence that is generated today that actually makes it through the bridge from the research environment to the real world. And I think I often use this slide when I speak to residents and researchers, and I always my advice to them is always look at the bridge, always find the bridge, because if your goal is if your goal with research is to ask a question, get funding to execute the study, publish the study, and present the study, and ends there, then we should consider that a failure. We shouldn't consider that a success. The only thing that I think we should consider a success is if we're able to make this last, but often most difficult step in the circle of our academic world. So to address some of these issues, we felt that we needed more transparency, we needed more higher quality data than we have today from the operating room. And we came up with this idea probably more than 20 years ago. I think it was 1999, where we started talking about acquiring higher quality data from the surgical environment. We couldn't, at that point, there were a bunch of technological, legal, ethical, and other barriers that we overcame. In 2014, we were able to introduce the first generation of what we called the operating room black box. And that introduces high quality audiovisual capture, but also high quality integration to existing data sources, where it's existing video sources, devices, engineering systems, physiological data of the patient, some other data from the electronic health record. All of this massive amount of data perfectly synchronized and visualized, and which gave us also introducing emerging technologies such as wearable devices and eye tracking and so on and so on. So all these sources of information that are perfectly synchronized and allow us to look for these hidden dependencies between factors that could contribute to intraoperative adverse events or postoperative clinical outcomes. So in order to answer this important and massive question of continuous improvement in the operating room, and the question of what are the factors that determine that a patient will recover quickly after surgery and go home after a couple of days, and a similar patient will suffer a major complication. These questions cannot be answered without holistic a study of the operating room environment, and this is what we were trying to achieve here with the OR black box. And now, as we continue talking about building a high reliability organization, I think that more than ever we have we need access to higher quality, objective data that will give us this accurate perception of reality and will eliminate this phenomena of work as done versus work as imagined. So the fundamental of building high reliability organization is objective, reliable, and actionable measurements, objective, reliable, and actionable definition of factors or key performance indicators related to the process and clinical outcomes, and then make this transition, that information and measurement that will allow us to make this transition from reactive to proactive. And that's one of the components, objective measurement. And the other one, I feel, which is equally, if not even more important, is the culture, building the culture of trust, building the culture of tolerance for error, where we can accurately capture error, study it, learn from it. And this transition from when we talk about errors and adverse outcomes and failures, this transition from focus on individual to focus to a system, which we all agree is important, but making that a reality on the ground and engaging our colleagues at the front lines is a very difficult task. So when we embarked on this work, we wanted to ask a few questions that matter to us. We wanted to know whether we can, by introducing objective machine-generated data capture in the operating room, where we can create this foundation for measurement and constructive feedback, which is which we so desperately need. Can we use that to enhance education and make this transition from one-size-fits-all curricula to specific individualized targeted educational interventions based on real educational needs? Can we use this information to improve our performance and reduce variability? Can we really engage our colleagues and the entire organization in this quality improvement process? And this engagement is really critical for the success of this process. We've all observed some of these initiatives that are done by various consulting firms that all look great on paper. They all look great at the annual glossy reports. But we all know that without this engagement, without this organic growth of the improvement interventions or solutions, they will ultimately be doomed to fail. We also wanted to know whether we can reduce costs, which is so important these days, maybe not at Stanford, but everywhere else around the world. And can we use this to also, the billion-dollar question is, can we use this to improve patient outcomes? One of the first initiatives that we developed together with our computer science colleagues at the university was to develop this AI-driven de-identification algorithm that helps us protect the privacy and confidentiality of every member of the team and make sure that this process is confidential and non-punitive, which is critical. And we achieved that. We've shown that AI can really help us de-identify this information by design. The other thing that we felt that AI, obviously you can imagine all these various data sources, they generate tremendous amount of data or information, of data that we have to transfer into from unstructured to structured and then into meaningful information that actually matters to clinicians and hospital leaders. So another interesting initiative that we worked over the years is use machine-generated metrics to quantify performance, and performance not only based on kinematics, but performance based on kinematics combined with clinically relevant events in the operating room, like bleeding, thermal injury, and other intraoperative adverse events. And this is an example of some of our engineers developed also a data capture platform, AI-driven data capture platform to acquire data from open conventional surgery, which has been traditionally a major challenge for us. And why do you do it? It showed us a couple of things. The first, it showed us that there was a tremendous variability in performance in the operating room. Second, it showed us that if we objectively track intraoperative adverse events, these events were much more prevalent than we initially thought. So on average, for every 2 hours of surgery, there is one high severity intraoperative adverse event. We normally don't register that. Normally, we don't study it. Normally, we approach it with shit happens. And this is part of our work. But a highly reliable organization will capture those, we categorize these intraoperative adverse events and develop mitigation strategies to reduce those. We've shown that by investing in improving technical skills, that results in reduction in high severity intraoperative adverse events. So we found that for every 10 points increase in the quality of the technical execution of a surgical task, that results in 10% decrease in the risk for high severity intraoperative adverse event in the operating room. And there is now a lot of evidence suggesting that technical performance is an independent predictor for postoperative outcomes. It was shown initially by the Michigan Collaborative in bariatric surgery, and then we showed similar results in complex upper GI cancer surgery. We've shown it in urology, gynecology, and a bunch of other procedures. So we also, as we were studying, as we were getting deeper understanding of the factors or the technical factors that lead to postoperative adverse event, we found not surprisingly that surgery or a successful execution of a surgical procedure requires much more than just dexterity, and this is something that we've talked for a long time but done very little to improve and learn from, is the impact of the so-called non-technical skills or teamwork, communication, situational awareness, and so on. So we partnered with our colleagues from the Human Factors Center a few years ago at the University of Toronto. I looked at a couple of things. We were inspired by the Safety 2 movement, which was kind of discovered by Professor Holnagel in Denmark, where the safety one is the traditional look at improving safety, which is, let's see the failure, let's see the adverse outcome and learn from it, do a root cause analysis. Safety 2 was let's understand the near miss and understand what do we do as a team, or what can we do as a team to, despite failure and variability and malfunction, to still achieve good clinical outcomes for our patients. And this is why studying resilience supports is even more fascinating than studying safety threats. Studying the near miss, where the outcome was good, is even much more is much richer in data than studying the adverse outcome, because the near miss, the ability, understanding what a good team does in order to recognize an intraoperative adverse event or a crisis situation and how they recognize it and rectify it in order to still achieve good outcome is extremely important. And I think the future of improvement in surgical safety will require understanding both of these mechanisms and using both of these rich data points to construct effective quality improvement interventions. So some of the work that I think has been pretty interesting for us was studying the World Health Organization surgical safety checklist, and I've looked at the stats from many institutions around the world, and I have not seen a hospital so far where the compliance is anywhere below 99.6. And obviously this is self-reported. This is just a click a checkbox in Epic whenever a surgical procedure is executed, and we can see that the reality was very different. The reality on the worst to the best, and here this is based on about 24 hospitals where we studied this, is the variability is pretty tremendous, and the opportunities for improving compliance, and not only compliance, which is was it done at the right time, but also engagement, which is how many people actually of the team participated in this information exchange event, and the quality, which is how many of the topics that we should have discussed during the surgical safety checklist were actually discussed. And we have identified some really interesting patterns, including here at Stanford, that will give us tremendous opportunities for improvement. And here the improvement is reduction of never events, which are much more prevalent than we all think they are. So the competency, the other point that I wanted to talk about a little bit is because I'm really passionate. That's how my career started in improving surgical education. was, and that was, again, I started my PhD in 99 and finished it in 2003. And I had much more optimistic expectations about the future of simulation and competency-based education than what really happened in the past 20 years. So I think it's still frustrating that we still rely on subjective assessment when we provide feedback. That results in often non-actionable and meaningless feedback. We still can't define performance standards of both technical and non-technical performance, and what's acceptable and what's not acceptable. We still talk about competency-based education and simulation as nice to have and not must have. We all know that delivering high quality education is very expensive. So the question of who will pay is still, in many places around the world, the elephant in the room. We still rely on subjective criteria when we select, promote, and certify surgeons. And the last point is really interesting, because a few years ago, we asked every general surgery program director in Canada, and there are 17 programs in the country, to tell us of the graduating class, how many of the graduating residents they feel are ready to practice independently. And the consensus was that between 5 and 15% don't have the technical proficiency to execute independent surgical procedures. And yet we graduate these individuals and we unleash them to the public. So this is usually how competency-based education works. We often provide some superficial feedback, and probably one of the most common feedback I've received from residents and fellows is we need higher quality measurement and we need higher quality feedback and coaching. So this is what I think AI can do in order to deliver this at scale. There are now a number of publications around the world suggesting that we can that a machine-generated, computer vision-driven assessment of technical performance is as good, if not better, than the manual subjective assessment by the mentor. We've shown that in a number of initiatives that we have done, and we can also use this to drive AI-powered coaching and provide continuous feedback, not on randomly selected cases, but on every single case done by every single resident. And I'll finish with a few studies, a few randomized trials that we've executed over the past few years, looking at the impact of this information on and these approaches on improvement of technical performance and reduction of intraoperative adverse events. The first one is the principle of deliberate practice, which was introduced by Professor Erickson in Florida. He studied a number of professional athletes and elite musicians. And basically the concept is somebody needs to perform a task. This task needs to be, the performance needs to be rigorously assessed. And then based on that assessment, we can provide either specific feedback through coaching or specific simulation-based training. And that will conceptually result in improved performance. We tested that in the operating room through a randomized trial. We selected two groups of residents, senior residents. They all performed a procedure. One of them received the traditional feedback, which the mentor usually provides in the operating room, and the other group went through rigorous assessment, specific feedback, and had the opportunity to practice in the simulation center to improve their performance. And they both groups performed a surgical procedure in the operating room without too much surprise. We demonstrated that the group that went through deliberate practice significantly outperformed the conventionally trained group, and we were able to significantly reduce the learning curves. The other concept that I think is very relevant to the surgical environment and other areas in healthcare, of course, is the concept of coaching. We have been capturing video and using this video to generate various metrics during a surgical procedure, and use that video to provide structured feedback. We showed in this randomized trial that we did a few years ago, that actually in order to deliver meaningful coaching session required no more than 10-15 minutes, where we highlight good practices, bad practices, areas where the learner performed well and areas that they didn't do so well. And through a randomized design, we showed that, again, not surprisingly, the group that went through coaching significantly outperformed the conventionally practicing group, and we were able to reduce the number of errors and intraoperative adverse events with 50%. So I think I'll here towards the end of my presentation, I think the future of surgery is really data-driven. I think that by introducing high quality or extracting high quality, objective and reliable data, we will make not only surgery but surgical education and surgical practice more precise. We'll make it more predictive. I think transparency is an important part that will help us make this cultural transformation, and really bringing data in everything we'll do at large scale will help us make this transition from reactive that we practice today to proactive, and from safe to ultra safe. So my final few thoughts, I think we need to introduce this open and transparent approach and holistic assessment and critical reflection of everything we do in our daily work. I think modern technology and especially modern data science and various AI methodologies will allow us to answer a bunch of clinically relevant questions, but clinically relevant is the key word here. And in order to avoid this development of technology for technology's sake, which we often see in healthcare, I think it's very important, if we want to make improvements in outcomes, to invest in studying our processes and design data-driven solutions, not that are targeted, that are individualized to the needs of our teams, of our frontline practitioners, which is different than the traditional approach to education and quality improvement, which has been one size fits all, a curriculum developed by somebody that then all of us are trying to implement. I think data science will replace many of these dogmas in surgery, and many of these traditions that we've been trying to break for decades, and it's so difficult to do. And I think the final point, which is I think the most important one, we will have the technology, we will have the commitment and the investments necessary. We've been doing that for a long time, and technology, but we will fail unless we understand and value the culture and attitudes to safety, which I think should be the foundational effort when we try to introduce some of these solutions. So again, thank you for the opportunity to share some of our experience, and happy to answer any questions if there are any.
Thank you very much, Dr. Grantcharov. I'm sure everybody will join me in a virtual round of applause.
Thank you.
Thank you. If anybody has any questions, feel free to put them in the chat and I can read them out, or you can raise your hand if you'd like to come off of mute and ask a question. But I can get us started. Dr. Grantcharov, I was really interested in the feedback loop, the reflection, and how you actually integrate what the black box sort of tells you into the routine of your daily work, right? I'm just thinking about myself and how often I reflect on my work, and it's usually like an annual type of review, and that's not really meaningful for continuous improvement. And I'm just wondering how you found that, where it's been successful, how do you integrate? You mentioned coaching, but how do you integrate that into kind of routine work for improvement?
Yeah, so how we operationalize that is really the billion-dollar question. I can tell you that I have video recorded every single surgical procedure I've done since I was PGY2. And I was when I was moving here to Stanford last year and cleaning up my basement in Toronto, I saw all these VHS tapes, then CD, and then DVDs and external hard drives that I've captured over the years and collected, and it's difficult, if I spent 6-7 hours in the operating room, it's not easy to go back home and spend 6-7 hours reviewing the performance. And I think so. And this is probably one of the main reasons why we failed to operationalize it. It's just not feasible. We don't have we have only 24 hours in a day, and we have a bunch of other things we want to achieve outside our improvement of our skill and performance. So I think what has happened in the technology development in the past few years can really revolutionize how we can deliver this at scale, and how we look for what we call segments of interest or procedures of interest, which with high value, educational value. We don't need to review hours and hours of surgical procedures where everything is an autopilot, but we need to review these areas where there is an adverse event, where there is an adverse outcome, where there is something that is outside the norm. And technology, AI, and data science can really help us operationalize this. So as I showed before, we were able to reduce the coaching intervention to about 15 minutes. And I think all of us can spare 15 minutes. It's just, and of course, it's not that simple. There are a number of other operational tasks here. How do we promote this culture? How we reward good teachers? How we measure the return on investment on initiatives like that? Because the reality is, these days, every time we invest in education or anything else, there has to be some return. And I think investing in education and investing in quality improvement, it's really an investment. It's not an expense. So I'm not sure that completely answered your question, but I think generally we have much better opportunities today to identify educational segments that we can use for coaching and improvement than we were maybe 5 years ago.
Yes, great. Thank you. I see, Ron, you have your hand raised. I also see a question from Sarah Singer in the chat. Ron, do you want to go with yours, and then we'll go to the chat?
Yeah, thank you, Teo. Your vision and kind of commitment to quality improvement in surgery is really kind of inspiring. And obviously, you've met with great success in helping many other institutions across the U.S. kind of adapt this review and improvement process cycle and really fully operationalize it. Your experience here at Stanford this last year of trying to do the same thing locally from inside the ropes as you would has been, I think, a little challenging, perhaps not unexpected. What has been your experience here, and how do you see the way forward to fully adapt the capabilities of the black box system to improve the quality processes here at Stanford?
So that's a massive question, Ron. But I think the key to success here is the understanding what are the pain points, what are the needs, and stay focused on solving those. I think what we're trying to do today is, or we tried to do earlier here at Stanford, is this could have gone in so many different directions, and we've been trying to chase all these directions rather than focus on 1, 2, or 3. And as you know, we had even this morning had a couple of conversations. We can use this to improve efficiency. We can use this to improve compliance. We can use this to improve education. And in order to operationalize this, requires proper governance, requires proper operational leadership and execution. And again, it's every institution is different. I can tell you it's Stanford is very different than University of Toronto, and what worked there probably won't work here, and the other way around. So I think we've gone a long way to in understanding how to operationalize this, how to govern the data, and how to prioritize our efforts, which I think will be critical for the success of something that is so massive and gives so many opportunities.
Thank you.
Yeah, I think Sarah's question kind of follows a similar vein to mine and Ron, but is there anything more to add about what distinguishes a helpful approach of providing feedback using the black box data versus a less helpful approach, specifically, I guess, where it means that surgeons or teams welcome that feedback and act on it? Is there anything more to add?
Yeah, I mean, it's we're actually working on an exciting project with Sarah to understand some of this and define some of these opportunities. I think what we've done so far in surgery is what I talked before. It's a reactive improvement. Is we wait to see statistically significant differences in outcomes. We wait to see morbidity and mortality event or a never event, and try to do root cause analysis, which almost always fails because there is no objective data, and there is a limit of how effective interventions based on a review like that will be. I think the real opportunity now is we can learn from the success. We can learn not only from the failure, but we can also learn from the success. We have the opportunity to again get out of these silos where a bunch of residents try to learn from their experience, or just a bunch of surgeons try to learn from their experience. I think understand much better now that the successful execution of a surgical procedure requires a team-based multidisciplinary approach. So some of the opportunities that we're working on right now with the teams here is how can we design a multidisciplinary forum where we or what we can learn forum where we see our failures, learn from them, but also see our successes and celebrate them, and identify these behaviors that make us unique and strong and an amazing place to practice. So by better understanding those processes and sharing these learnings in a collaborative way, I think we will create this continuous circle of improvement.
Yeah, so I think then, so then Phyllis's question is, what opportunities are available for residents so they can be taught in a different way? And I think it's interesting, you know, this is like continuous learning, but is there a way to kind of move this further upstream into maybe medical education in a way?
Yeah, so the resident, I can remember how I practice, and I don't think that much has changed in 25 years since I was a resident. I think we still struggle with providing meaningful feedback. We still struggle with providing objective, reliable assessment. And I think this is one of the things that make me so excited now, is that we now can change this. Now now any resident can do a procedure in the operating room. They can go back to after the day in the OR and look and have access to a video. They can have access to a machine-driven assessment of their performance that can identify areas or video segments where they did a really good job, and video segments that did a really poor job. They can share those with their mentors, and really that will be the mechanism to operationalize the learning potential of a video-based assessment and incorporate it in the continuous improvement and continuous education, not only for residents but also fellows and those of us who have been practicing for a long time. There is always something to improve.
Great. And with just a couple of minutes, I just want to ask the last question, which, so I'm a qualitative researcher, and so I'm very interested in, the cameras and the amount of focused information on what people are doing and how people feel about that and how that actually impacts their work. You talked about de-identifying people, I guess, so that they're not, identifiable, but then also you have to have some information to provide feedback in the way you were just talking. What work have you done around how people feel having that many cameras or that much kind of focused attention on what they're doing?
Yeah, so we've done some work to extract some information about the perception, and probably Sarah can talk a little bit more about what Sarah and her team are planning to do here at Stanford, and also across a few other institutions, to extract a little more information about what are the barriers, what are the concerns, and what are the opportunities. I think there is no doubt that this is something new for us. We're not used to this level of transparency, and also there are a bunch of psychological phenomena there that need to be studied in order to better understand what is the impact on our performance, the way we teach, and the way we practice. But again, I think generally having more transparency, having more opportunity to discuss success and failures and learn from all of those will be inspiring for many frontline practitioners, and we've seen a bunch of examples of either morbidity and mortality meetings, or what we can learn rounds, or multidisciplinary educational events where individuals and teams have really extracted a lot of value out of this transparency, and I think this is going to be the way we will practice in the future. So to answer that, there is a lot of stuff that we need to still study, and a lot of questions that need to be answered. But generally, this is going to be healthy for us as individual practitioners, as teams, as an organization, but also for our profession, and I think most importantly for our patients. Transparency and accountability are a good thing, are good principles.
I agree. Certainly, mostly as a patient as myself. Well, great. And I see that Sarah looks like she's offered to share some more information, as you suggested in the chat. But that brings us to our time. Thank you very much, Dr. Grantcharov. Another round of applause. Thank you much for sharing your work today. And thank you, everyone, for coming.
Thank you.
That was wonderful.
Thank you, Lisa. Thank you again for inviting me.